name is Tomas Dobrocky. I work in the hospital in Bern, Switzerland. Thank you very much for the kind invitation to present at this year's meeting. I thank the organizers, especially to my dear colleague, Dr. Saravana Kumar, for this very kind invitation. So I will talk about the pathology of spontaneous intracranial hypotension. Now in the first lecture, more on the Aetiopathologenesis, and then the second one, it's more about the diagnostic workup looking at the spine. So let's go through these points in this first presentation. So what are we talking about? What's the definition of SIH? So it is a loss of CSF, of cerebral spinal fluid. And usually the patients present with orthostatic headache. A lot of them also may have vertigo, nausea, or cranial nerve palsies. Why do they have that? Because there is a traction on the pain-sensitive fibers as the brain sags, and this causes the orthostatic component of the headache. There is traction on the cranial nerves, and that is why some of the patients may complain about cranial nerve palsies. As you see here, there's for sure traction on those nerves. And usually it recovers when the CSF loss has been treated. What's the incidence? So if you might think that subarachnoid hemorrhage is something that you might see in your clinical practice, yes, there is an incidence of about 5 patients per 100,000. Well, what about SIH? This is probably about the same incidence. So there is, those patients are around. You just need to look very carefully and really find them, because I'm sure you're going to see one of them in your clinical practice. What is the underlying problem? So we have CSF resorption and CSF secretion, and that leads to a certain kind of a volume. In those patients, we have a decreased CSF volume because there is a leak, there is a loss of CSF. So we have the CSF resorption, but in addition to that, there is a CSF leak. So the entire system gets out of balance, and we have a decreased CSF volume. What about the diagnostic criteria? So patients usually have an orthostatic headache, and according to the criteria, there's a low opening pressure on lumbar puncture, and there are signs of CSF loss on spine and brain imaging. However, there's a caveat to this, because the low opening pressure is actually only present in about 1/3 of the patients. So actually, this should not be termed SIH, hypotension, but actually it should be called spontaneous intracranial hypovolemia. Whatever, this is the way it is, but just to give you an idea, the low opening pressure is actually very rare in those patients. Very important, spontaneous intracranial hypotension is not post-lumbar headache, it's not post-surgery, it's not in patients who have a drain. These are different entities and need to be considered separately. So it's SIH occurs spontaneously, not after any kind of procedures. Okay, so just a very basic and brief understanding of CSF before we get started. I'm sure you're all aware of the cerebral spinal fluid, where it's located. What is it important for? It's important for protection of our brain. If there's any trauma, this helps to protect our brain. There's a buoyant force that uplifts the brain, and if this is missing, there's the typical brain sagging. And this is important for homeostasis and disposal of metabolic waste products. So usually it's a clear fluid, and these are the functions of it. We have about 100 to 200 cc of CSF, and it's resorbed about 4 to 6 times, and this is the typical homeostasis. There are different volumes, so it is important in our brain. We have intracranial space, we have the parenchyma, we have the CSF, and the blood. Usually the brain parenchyma obviously is the largest compartment, and then we have about 10% CSF and 10% of blood. In patients with SIH, there's a decrease of the CSF component, as you can see here, and this needs to be compensated. And usually the compensation occurs by the component within the blood volume. It would be nice if it would be the brain and all of us will get a little bit smarter, but unfortunately that's not true. And the missing volume of CSF is compensated by the blood volume. This is why we have the typical findings. So now we need to look at the underlying pathologies that can actually cause SIH. So what do we need to look out for? And we'll go through each one of those separately in a slide. So we need to look for spurs, osseous spurs. We need to look for nerve root cyst. We need to look for CSF venous fistulas. And there might be other etiologies that are not proven yet, like the hypercompliance of the thecal sac, vena cava stenosis, or a decreased CSF secretion. So we'll go into detail on the first three of those pathologies. So what's a microspur? We are referring to that as a osseous protrusion from the disc or from the end plate of the vertebra. And this is like a knife. It's really sharp. If you have seen this on surgery, it's like a knife that cuts the dura. It cuts the dura, and this is why there's efflux of CSF from the intrathecal compartment into the epidural compartment. They are actually very small findings that in a normal patient you wouldn't even report. But in these patients, these are the pathologies that cause the problem. So these are the small, tiny spurs, as marked here with the red arrow, that penetrate the dura. Sometimes they can be very large, and as in this case, large disc calcification, but usually this is not the case that you can find them this easily. Usually they are very, very subtle. The second pathology would be nerve root cysts. So these are cysts at the axilla of the exiting nerve root. This is a weak point, and they can protrude here. And this is not dural covering, but this is just arachnoid membranes, and they can easily rupture, and they can be an efflux of CSF again into the epidural space. So this is how it usually looks like on myelography. This is the cyst. This is not the pathology yet, but there is a efflux of contrast media into the epidural space clearly here in this patient. Okay, so this is the same then on post-myeloma CT. And the third important pathology we're going to touch is the CSF venous leaks, CSF venous fistula, I'm sorry. There's the cyst, and you can see there is contrast within the paravertebral vein here that's effluxing from the cyst into a vein. What are those fistulas? So usually we all are aware of granulations in the transverse sinus that are important for CSF resorptions. The same granulations or very similar structures have been demonstrated on nerve root cysts. Histologically, there are granulations on nerve root cysts, and they are important for the CSF resorption in the spine. What happens in patients with a CSF venous fistula? It has not been demonstrated yet what it is, but if we consider this being the nerve root, then that's the nerve root cyst, normally there is a subtle resorption through the granulations. And for whatever reason, when there's a large cyst, there's increased resorptions through those cysts and through those granulations. And why it occurs, why they rupture, we are not aware of that yet. So, but this is the postulated mechanisms how these CSF venous fistula occur. Okay, there's a very important difference to differentiate between these three pathologies because we need to look if there is CSF in the epidural compartment. So this is the thecal sac, and we see that there's fluid in the epidural compartment. It is important. Those collections are called by Richard Farb. He has termed them the spinal longitudinal epidural CSF, or SLEC. If there is SLEC, if there are SLEC positive, we're looking for a spur or a CSF root cyst that has ruptured, because there is always liquid in the epidural CSF or epidural space. Whereas in patients with a CSF venous fistula, there's efflux of CSF into a vein, and there's no epidural CSF, so they are SLEC negative. So this is very important to distinguish for later on the diagnostic workup. We'll now go and look at brain imaging. What's the important finding of brain imaging? Wouter Schieling from Los Angeles, he has first termed the important signs as SEEPs. Those are to be found on brain imaging in patients with SIH. So those are the subdural collections, enhancement of meninges, engorgement of the veins or sinuses, pituitary enlargement, and sagging of the brain. Now I'll show you some examples and a score that we have proposed in order to have a quantitative measure. So those are classical findings in SIH patients where you have these rounded sinuses, very round, usually they are triangular shaped and not this round. Typically, what also you can also see, you have this diffuse meningeal enhancement on both sides, and not just supratentorial, but also the tentorium itself is clearly enhancing. There's an important difference. If you see a CSF leak or a patient with a SIA patient, you can see that there's a generalized enhancement, not only on the side when there is a small subdural collection, but also on the other side and also on the tentorium. Whereas in a patient with a subdural hygroma, that's not an SIH patient, there is only a reactive enhancement on the side of the collection, but otherwise the meninges are not enhancing. So this is very important to differentiate the generalized and the reactive enhancement. As you have seen before, there are subdural effusions, usually bilateral. Sometimes they can also be just unilateral. Pituitary enlargement, usually the pituitary gland the size can vary, but the gland is too large for the age and the sex of the patient. Tonsillar descent, we can see that sometimes in patients this is very severe, but the typical findings also of this brain sagging, where the entire brain is sagging down because of the lacking buoyant uplifting of the CSF. Sometimes you can also see the intercavernous sinus. This is the T2 hyperintense line underlying the pituitary gland. This is also a kind of a venous engorgement. What is the problem? That none of those signs that I've shown you before is pathognomonic, so they can occur in other diseases as well, or other pathologies. So for example, the pituitary gland size can vary due to the sex and age of the patient. Tonsillar descent we can see in Arnold Chiari. Subdural hygromas, they can occur in the elderly population, and the pachymeningeal enhancement can occur after lumbar puncture. So is there any sign that helps us to differentiate those, or to combine? How can we proceed? So we have published a paper on a score where we combine those signs. These are illustrations of possible signs that you can see in patients with SIH, subdural collections, rounded sinuses, enlarged gland, superficial siderosis, or the dural enhancement. The same in the lateral projection, where you see that the sagging, the mammillapontine distance has decreased, the prepontine and suprasellar cistern are effaced. So these are the classical findings in SIH patients. If I would ask you to tell me who this person is, maybe you can see that this might look like a tennis player dressed in white, living where I do live. You might figure that this is Roger Federer. If I show you another picture, this is a guy standing holding something in his hand. There seems to be a logo in the background, and he seems to be wearing something very typical for him. So that's Steve Jobs. So what I want to say, if you combine different signs, even if it's a blurry image, you can get what the picture is actually showing. And this was the objective of our paper, where we combine different signs. So we have combined 6 different signs that are to be seen in SIH patients. So that's there are 3 major and 3 minor signs: engorgement of venous sinuses, pachymeningeal enhancement, the effacement of the supracellular cistern. They each score 2 points. And there are 3 minor signs: the presence of subdural collections, the effacement of the prepontine cistern, and the decrease of the mammapontine distance. And if you add up this gives you a score. And depending of how high the score is, you can guess, or you can say how high the likelihood of finding a CSF leak will be. So in patients with a score higher than 5, there's a large likelihood, or a high likelihood, of finding a CSF leak. So just to summarize them, there are 3 qualitative signs. So the presence of subdural collections, the presence of dural enhancement, engorged sinuses, and 3 quantitative signs: the effacement of the prepontine cistern, of the supracellular cistern, and the mammapontine distance. And so why might such a score be important, the brain SIH score? Because this might help you to assess the likelihood of an underlying spinal dural leak. It's important to triage patients, because you might not want to be so aggressive in someone who has a very low likelihood, and it might also facilitate the communication in between your colleagues, because if somebody tells you the patient has got an aspect of 8, it's evident for everyone who we are dealing with. Whereas with SIH patients, sometimes it's very random how people communicate. So this might be also a good thing. We have a score. There's an app for the score, and you can download this in the App Store. So coming to an end, the low lumbar puncture. The opening pressure is another reliable sign in SEI patients. The brain SIH score is a 9-point brain MRI based scale that may help to communicate, triage patients who are suspecting of having SIH. It is important to make the distinction between SIH and other form of induced intracranial hypotension, for example, after lumbar punctures. And the T2 weighted MRI of the spine is a very important tool to differentiate between patients with different leak types, if they are SLEC positive or if they are SLEC negative. Thank you very much. It was a pleasure, and I hope that you will join also for the second lecture on diagnostic workup looking at the spine. Thank you very much. Thank you for the kind invitations for this course, especially to my dear friend Saravana Kumar. I will continue with the second lecture in SIH patients on the diagnostic workup of the spine. As we have mentioned in the previous lecture, there are 3 important pathologies we are looking for. So there are the osseous spur, so disc protrusions or spondyle osteophytes that are originating from the end plates of the vertebra that have penetrated the dura. There might be the nerve root cysts that have ruptured. Both can cause epidural CSF. Or the third pathology that we're looking for is a CSF venous fistula. So let's go and see how we can proceed in the diagnostic workup. So this is the usual case, how the patient comes in, probably orthostatic headache. We did the brain MRI as mentioned in the previous lecture. We can do the brain SIH score to see if there's a high likelihood or a low likelihood to finding a leak. Then we do the spine MRI and see if the patient's SLEC positive or SLEC negative. As mentioned previously, this means that there is spinal longitudinal epidural CSF collection. So let's go and see what we can see on. So this I have already shown this one in the previous one. So SLEC positive, the spurs and the nerve root cyst, and SLEC negative, these are the CSF venous fistula patients. We always do a fat suppressed spine MRI, because this is the best sequence to see those epidural collections. Here you can very clearly see that there is abnormal CSF in the posterior epidural space. You can nicely depict the dura and see that there is clearly CSF in the epidural compartment. Here in this case, you can guess that there might be something, but definitely this is a lot better to be seen on the fat suppressed image. So this is the one we always do on all kind of those patients. You might say, do we really need to go further and see where the leak is localized? I can show you a case to try to convince you that this might be important. So in patients who are refractory to conservative treatment and non-targeted epidural patching. So this patient has been previously operated on various levels, and apparently the leak has been sealed, but there is extensive hyperintensity in the spinal cord, because when you see when you look at this the patient's myelography, this is the intrathecal contrast, and you can see that there is complete occlusion at the level of the previous surgery. So there is arachnoid granulations, or this is completely adhesive here at the level, and there is no CSF flow at all, and this causes the severe myelopathy. So yes, the leak has been sealed, but there's of course a severe collateral damage that causes patient discomfort and patient complaints. What are the challenges when we face when we want to localize the CSF leak? So first of all, the objective is to tailor the surgical approach, or the targeted, have a target for blood patching. And this is challenging since the leak can occur in anywhere along the entire spine, even though the most leaks are at the level of the thoracic spine or cervicothoracic junction. And when we're doing a diagnostic or dynamic myelography, we have a flat panel, and the size, of course, is a lot smaller than the entire spine, so we cannot cover it with one flat panel. So this causes or gives us certain challenging we're faced with. A lot of leaks are very high flow leaks, and there's immediate epidural leakage into the epidural space. So this means that we need a imaging modality with high temporal resolution to actually depict it. And sometimes doing so in the cervicothoracic junction is very challenging, because there's a lot of bone superimposition or shoulders. So this can cause another challenging part. So there are three important dynamic myelography techniques: the conventional one, the digital subtraction myelography, their dynamic CT myelography. We'll go through each one of those. And there are two other techniques that sometimes are being mentioned as being dynamic, but I would disagree: the post-myelography CT and the intrathecal gadolinium MRI myelography. I'll explain very shortly why I don't think that these are dynamic techniques. The reason is, in the last two ones, you perform a lumbar puncture, you inject the contrast, then you transfer the patient to a CT scanner or MIR scanner, and this takes several minutes. Even if you're quick, this will take 15 to 20 minutes. And then what you see, that there is contrast in the epidural space, but you don't have no resolution. So this is you don't know where the contrast has spilled. So there is no way these should be called dynamic imaging techniques. What we want to I want to stress that a lot of times the epidural collections are multi-lever, very extensive, and so there's no way in this patient you can say, or you can localize the leak just by looking at the static brain MRI, spine MRI. And in addition, a lot of patients show multiple disc protrusions or calcified spurs or multiple cysts. So where is going to be the leak site in this patient? So this is another point that underlines the importance of dynamic imaging. So if we did the spine MRI and we saw that the patient is SLEC positive, we go on for dynamic myelography. How do we do a dynamic myelography? So you inject contrast into the epidural spine, into the intrathecal compartment. You usually fix the patient on the table. Either you have a tiltable table, or you have to put a pillow underneath their pelvis. Usually the contrast is going to lay down in the thecal sac because it has a higher gravity than CSF. And basically what you need to do is to tilt the patients. We usually do a skin marking, so a small radiopaque marker, so we know what level actually we're looking at, because you might easily get confused when you're tilting the patient. And you're going to adapt the patient positioning according to the pathology that you're looking for. Prone when you're looking for a spine spur, or lateral decubitus when you're looking for a ruptured nerve root cyst. So this is how our setup looks like. You fix patient's feet to a table. You have a tiltable table, and what you want to do is this: while you're tilting the table, you want to see how the contrast is running down the thecal sac from the lumbar region to the thoracic spine on the cervical region. If you don't have a tiltable table, all you need to do is provide a pillow underneath the patient's pelvis to have this gradient, and inject while you're doing the fluoroscopy run. What are we going to see? So this is one video. This is the skin marker. The patient is freely breathing. This is cranial. This is caudal. You see that the contrast is intrathecally. It's arriving. It's still intrathecal. It's still intrathecal. It's still intrathecal. And now it has spilled into the epidural space. So this is the level of leakage, and this is clear and evident on this image. It's also important to say you can see how fast the contrast has spread within the epidural space. So if you don't have this temporal resolution, there's no way you can say that the leak has occurred at this level. Then you can easily miss it. This is another example where you can see there's already some intrathecal contrast. Now there's more contrast, and this spills again here at this level. So it's very easily to depict it here. This is a these are two very nice examples of classic ventral dural leaks in a patient with an osseous spur. This is another one in a patient who had the leak at the cervical thoracic spine. Initially, we didn't see the leak, but then we did a Valsalva maneuver. The patient has been asked to do a Valsalva, and you can see that the leak is here at this level. So this might be another technique to help you to perform a Valsalva while you're doing the examination. What's the difference is when we're looking for leaks that have originated from a nerve root cyst, the positioning is in lateral decubitus on the side of the suspicious cyst. Again, exactly the same. You tilt the table, and what you're going to see is the filling of the cyst. As in this case, this is an abnormally large cyst. And when you go a little bit later on, you can see that there's contrast in the epidural space. So this is the leaking cyst, and this is a very good target for a surgical closure of this ruptured cyst. What do we see on post-myelog CT? We see that there is the dura, there's epidural contrast. We see that it's very extensive. The epidural contrast has extended over several levels. So again, no localizing value of post-myelo CT. And then you can see you can see those small osseous spur, and as here, this is the underlying spur that has caused the leak. There are some pitfalls. So when you perform a lumbar puncture, obviously there might be some contrast in the epidural space at this level, but the leaks at this level that are spontaneous are extremely rare. So you have to be aware of this, because when you withdraw the needle, usually there is always some contrast. So this should not be interpreted as the leak site. Also important in those patients, you can sometimes puncture the subdural compartment. It's very rare, but you can do that. Or you can also have epidural contrast distribution. So you need to be sure that you're in the intrathecal compartment, which might be sometimes challenging because the thecal sac is so poorly distended and it's so hypotensive that you actually cannot penetrate the dura. So that's why we usually puncture in the sitting position, because then the thecal sac is better distended. Okay, so sometimes we might have the problem that because of superimposition in the cervical thoracic region, we don't really see the region of interest. So we see in this patient, the thoracic spine is usually not a problem in the matter of visualizing it. There's very good visibility, a very good imaging quality. But as we advance a little bit higher up, you can see as we go up into the cervicothoracic junction, the quality becomes very poor because there are the shoulders. Even if you change the positioning of the arms, it is really tough to see that region. And you see that there is a leak, but you just didn't see the level where it's leaked. So we have a kind of a black box region there. So what can we do? This is the dynamic CT myelography technique. So we do the imaging on the CT scanner. In order to have a gradient, we have to put the patient on a pillow, on a cushioning. And based on the previous imaging that we performed, we can narrow down the scan volume. And then we rescan the same area within a few seconds. So we usually do 6 blocks with time delays of approximately 7 to 10 seconds. So you do 6 blocks so each one delay by 6 to 10 seconds. And the imaging that you get, this is the native scan, this is the sagittal image. After 10 seconds, it looks like this. You can see the contrast is arriving there. There's already some epidural contrast here. And 22 seconds later, after the injection, you can see there's extensive staining in the epidural compartment. And as you can see here, it's impossible to say here, is the leak here or there? So you need to really hit it on spot to be able to make the call that this is the level of leakage. And when we go back, you can see that this is the small osseous spur that we found there. This is another image. A patient referred to us from a different center where you can see the surgery was performed on the wrong level. It's just about 3 centimeters above, but the surgeon there's no way he can see the leaking one level below. So you need to really make a precise call on the target in order to be found during surgery. This is another one. This is the one with multiple spurs that I have shown before. You can see that the spurs at the level T23 or T45 are a lot more prominent, but the leak level is actually at T12L1, and you can see that nicely. The first time of contrast is staining the epidural space. A few seconds later, the entire epidural compartment is already full of contrast. Another one, this is one that has been performed in lateral, patient with a lot of suspicious nerve root cyst, and you can see contrast in the intrathecal space within the cyst, and then there is some contrast exiting the cyst. So this is the ruptured cyst, and this is already in the epidural space. Okay, so now we have looked at the SLEC positive patients. We now want to move on to the SLEC negative patients. So these are the ones that we're looking for a CSF venous fistula. How do we investigate those? The patient is lying on his side in lateral decubitus. We have to do it on 2 different days. So we usually do a right lateral decubitus on day 1, left lateral decubitus on day 2. And this is the images we're looking for. We're usually doing a digital subtraction myelogram. This is the first one is non-subtracted. You can see there's something here, and if we look at those images in a subtracted manner, we can see that there's a vein that is filling here, and this is the level of the CSF venous fistula. This is another example where you can see the staining of the plexus surrounding the nerve root, and it's going into the vein and then the hemiacegus vein. Just very briefly before coming to end, this is the therapy approach we have. So usually the bed rest in the beginning, that usually doesn't help in patients with SIH. Then we can proceed to supportive medication like caffeine, but usually patients don't have sustained improvement. Then we can go in for blood patching or embolization of CSF venous fistula or surgery. How do we perform a blood patch? We inject blood within the epidural space. We usually perform it in a non-targeted manner. It is interesting to see that a lot of times it improves, the patients improve on short term, but long term, to be honest, we see that a lot of patients do not improve. And if you bring back for spine imaging, you can see that there's still a leak after. Because if you see how the osteospurs looks like, they penetrate the dura, and how should they, I mean, this is open to discussion, but how is a blood patch going to seal it permanently, especially if there's a osteospur that's penetrating the dura? So maybe based on the leak type, this might not be as effective as thought. Surgery, how do surgeons approach? So depending where the leak site is at, they can do a lateral approach. But a lot of times the spurs are at the ventral part, and they have to go transdural, and they have to mobilize the myelin and have to approach transdurally, visualize the penetrating spur, and then seal the fecal sac. This is how it looks like during the surgery. This is already a transdural approach. The myelin has been lifted to the side. You're looking at the ventral dural, and you can see this is the small slit, and this is the penetrating osteospur. And you can imagine if you're going to do a blood patch there without doing anything about the spur, I'm not sure how this will permanently seal the leak. And this is after the spur has been removed. There's going to be a small suture here, and so yes, this is the surgical approach, just to give you an idea how those look like. The last 3 slides before coming to an end on a more endovascular subject that has recently appeared, thanks to Walid Prinjiki from the Mayo Clinic, who has shared some of his slides, and I have added a few cases of ours, where he found a very nice technique how to approach CSF venous fistula, where we can go from a transvenous approach through the acegus vein, hemiacegus vein. We can approach the level of the CSF venous fistula, advance a microcatheter, and embolize the periradicular venous plexus that is draining the fistula. And those are very promising results. One of our cases where we have embolized the periradicular venous plexus with onyx that has been stained in green here. And just to give you an idea how this looks like, the patient before has a generalized dural enhancement, a little bit rounded sinuses, and just 3 or 4 days after the procedure, the enhancement is gone, the subdural collections are gone as well, and as you can see, the sinuses are a lot smaller. And also the brain sag has improved, and also the pituitary gland that was enlarged and hyperemic has normalized. Okay, so coming to an end, the non-enhanced spine MRI of the entire spine with fat suppression is very important to make the distinction between SLEC positive and SLEC negative patients in order to have an idea what kind of a dynamic myelography technique we're going to use, because as I said, there are different techniques to use for different pathologies. Post-myelo CT or intrathecal gadolinium enhanced spine MRI have no localizing value, as I have shown you before. In order to depict or to localize, pinpoint the level of leakage in patients, we need a technique with a high temporal resolution, and I've shown you the 3 most important ones. And epidural blood patching in patients with SIH might often provide improvement on short term, it'll be long-term relief. A lot of patients, according to my experience, does not have permanent relief after blood patching, and the surgical repair of spinal CSF leaks can be curative and requires precise localization of those CSF leaks. Thank you very much.